Welcome to the NMQF Friday webinar. I'm Audra Chimeting, VP of Public Affairs and Communications, and I'll be passing the microphone to Gretchen Wortman shortly. This webinar is a not so narrow webinar focused on examining the unintended consequences of CMS fixed dose combination drug proposal. Gretchen Wortman.
Thank you, Adjoa, and good afternoon. My name is Gretchen Wortman. I am Vice President for Policy and Program of the National Minority Quality Forum, and in that role, I direct NMQF's Center for Public Policy. For those who may be new to the forum, NMQF is a 501c3 not-for-profit research and advocacy organization based in Washington, D.C. The mission of NMQF is to reduce patient risk by assuring optimal care for all. I'm going to repeat that. The mission of NMQF is and has been to reduce patient risk by assuring optimal care for all. Our vision is an American health services research, delivery, and financing system whose operating principle is to reduce patient risk for amenable morbidity and mortality while improving quality of life. For more than 25 years, NMQF has worked to ensure that health services policy and financing eliminate rather than reinforce or exacerbate the gaps in healthcare quality and access that are experienced by all patients and communities. Today, our policy briefing will focus on a component of the proposed rule for the Medicare Drug Price Negotiation Program for initial price applicability year 2029. Yeah, all of that is the title. This is a proposed rule that CMS published on June 12th. Specifically, this panel will address the manner in which the proposed rule recommends that fixed dose combination drugs be treated for purposes of identifying drugs that are eligible for drug price negotiation. Joining to me is an expert panel that will share their perspectives on the impact of the proposed language on patients, families, clinicians, and healthcare facilities. For the audience, throughout this briefing, please feel free to enter your questions into the Q&A box. The Q&A box, not the chat box. I will give our panelists an opportunity to answer any questions you submitted after all of our panelists have had an opportunity to present their information. Our first presenter is Dr. Shaili Gusani. She is Associate Director for Policy and Research of Bristol Myers Squibb. Shaili has accepted the daunting, possibly, challenge of establishing a foundation of understanding among us all regarding this not insignificant proposal. Shaili.
Sure, and thank you for the introduction. Hello, everyone. Good afternoon. I wanted to take a few minutes to review the policy that CMS is proposing in this year's Medicare drug price negotiation rule. The Inflation Reduction Act created the new Medicare drug price negotiation program, which allows Medicare to negotiate prices for certain drugs. Initially, the program was intended for medicines that have been available to patients for 9 to 13 years, depending on whether it is a small molecule or a biologic medicine. CMS is now considering a proposal that would change how some combination or fixed dose combination therapies are treated as qualifying single source drugs under that program, even if they are newer to market. Specifically, the proposal would treat certain therapies, like subcutaneous medicines, that combine multiple components and offer a different treatment experience to patients as the same medicine as earlier versions of that therapy. For example, think about an IV-infused drug that a patient would have infused over the course of an hour, perhaps through a port in their chest, and then you take that IV medicine, further develop it by adding another active ingredient to make it into an injection form that can be delivered faster, like a shot under the skin. And then picture CMS bundling those two drugs as if they offer the same value to patients. And not to mention CMS bypassing the fact that these medicines are considered separate medicines in the eyes of the scientific experts at the FDA. CMS has described this as a narrow policy change. However, many patient advocates, providers, and other stakeholders believe the proposal will have broader implications for patients and future medical innovation. That's because medicines that are selected for negotiation inevitably face unique or challenging market dynamics that impact patient access. And it's important that patients can access subcutaneous options or just options in general that can reduce time spent receiving treatment, lesser demands on caregivers, offer better safety from infections due to surgically implanted ports, decrease travel time to healthcare facilities, and make it easier to fit treatment into everyday life. So I will pause there and pass it back to you, Gretchen. I think you're muted.
Thank you. My safety net. The for the audience, what I failed to mention was that the rule was published by CMS on June 12th. It's still currently available for comment through an open comment period that closes on August 17th. So we encourage all of you here, regardless of your perspective on the issue, to engage in this public comment period. While the language narrow is included in the language that CMS uses in the proposed rule, I think the concern that we all have is that it is not at all narrow, and that has far-reaching implications for every participant in this healthcare research, delivery, and financing system, particularly as fixed-dose combination drugs become more available as options for patients. So we encourage you, and we're here today to encourage you to engage in this public comment period. Again, thank you, Shiley. Our next presenter is Dr. Peggy Rosenzweig. Dr. Rosenzweig is professor of nursing at the University of Pittsburgh School of Nursing, and she is representing today the Oncology Nursing Society. Dr. Rosenzweig.
Hi, and I'm happy to be here with you. Part of my work at the University of Pittsburgh School of Nursing and as Associate Director for Outreach at Hillman Cancer Center as well. But in my heart for many years, an oncology nurse. Part of my research has been in studying equity around cancer care and what is it that ensures that everyone receives optimal treatment and supportive care. And one of the things that really helps achieve equity is to make treatment as accessible and less burdensome. This is particularly true as we see the paradigm of cancer treatment changing so that patients who have advanced stage or metastatic cancer are no longer, okay, you'll receive palliative care. They are treated now, perhaps not for cure, but certainly for extension of time, and they are treated aggressively. This requires on the part of the patient and family a lot of commitment. It's commitment for years to come into the clinic, to pay for parking, to pay for childcare, to perhaps miss days of work. And there's this new idea of time toxicity that we ask of patients, as well as well-known financial toxicity. When we change drugs to sub-Q that have been traditionally given through intravenous, we make a world of difference for patients and families because it shortens the time that they have to be a patient, and it makes them more available to live their lives as they need to live them. we see this over and over again, particularly, for instance, somebody with metastatic breast cancer. If you can change the administration from an IV therapy to a sub-Q therapy, that means just everything. It might be every 3 weeks that they have to come into the clinic for years. And the ability to get in there and out of there, perhaps early, still not take any time off from work, or go after their kids are in school and they can be sure that they'll be home in time. These kinds of things are so very, very important. And it might seem, well, that's a minor change. That's not a minor change at all. When you ask patients and families, what does this mean to you? This is the core element of trying to make this really amazing treatments that are available today more accessible to patients, so that it does not make them all the time a patient with cancer, but makes them someone living with cancer who can well sort of demarcate that time and effort that they need. I think that the proposal needs to be much to be considered in terms of the patient voice and the patient experience, instead of a policy change that really won't have any impact.
Thank you. Peggy, a question I have for you before we move to Steve Horn is, as the system is encouraged to, I won't say move away from, but open the door to these alternative forms of making therapy available to this patient cohort, is there a risk of shifting some of the, what I would call sort of the administrative burden from the healthcare delivery system to the patient or the family or their caregivers? And along with that, are there attendant costs
Oh, that's
associated with
really,
that?
yeah, that's an excellent question. So we think, okay, if you have an IV therapy that's covered in the hospital, or, under the administration costs, that's not always covered for people, particularly those who have chosen high deductible insurance plans, and that's often patients perhaps with lower income. They are incurring such a copay with each visit. And again, we think, well, that might not be that much money. We are talking years and years of therapy for patients. So those administrative costs of having to have a bed in the treatment room, and of course, an RN administering the therapies, and all those costs that go into safe delivery of cancer treatment intravenously, can still, of course, those elements are there, and that it's a safe administration, perhaps of a sub-Q injection, but it is certainly much more limited. And, the price is in the time spent in the chair in the treatment room. And of course, that time becomes much less. So these are long-term financial issues, and we know that cancer therapy can bankrupt patients and families, particularly this chronic therapy at the end of life. And it's just so critically important that we consider all of these. So that's a really good point. The financial, every visit. We did a study at the clinic at McGee Women's Hospital, part of the UPMC system, and we asked patients what it cost for them to come in with patients with metastatic breast cancer for their visits. And this was, these every month or every 3-week visits. And on average, patients spent $84 per visit just to park, to come into the clinic, and to pay the physician copay. And that wasn't anything related to what the treatment cost might have been. And so for some people, maybe $84 a month isn't really going to be that big of a deal, but for many people, it really is.
And is it safe to assume that as they seek care through that clinic site, that they also need a companion, a caregiver, a family member to accompany them, and their attendant costs associated
Often,
with that?
yes. And
Okay.
sometimes even physically, people don't necessarily need to have someone with them, but emotionally, it's a very lonely place to be by yourself in the waiting room and in the treatment room. And so somebody coming along then means either the patient has to ask somebody, perhaps somebody from their faith community or somebody from the community to assist them. And sometimes that's very hard for patients to do, or they have to ask a family member to take time out to come with them. And again, perhaps one time everybody would say, sure, of course I will be there with you, but continue that ask over months and years. And that becomes a burden on the family member as well. So as our patients will say, run in and get my shot versus, spending some time getting an infusion. I mean, there are many papers that are showing patients very much prefer to have sub-Q administration of oncology therapies when they can. And it is a lesser burden on them all around.
Thank you, Peggy. And I think we may come back to that issue before the end of this session. Our next presenter is Mr. Steve Horn. Steve is Director of Governmental Relations for the International Cancer Advocacy Network. Steve, what are you hearing directly from cancer patients and caregivers about why treatment convenience and choice matter as much as clinical efficacy?
Well, thank you, Gretchen, and thank you to the National Minority Quality Forum for hosting this webinar. I've watched many of the webinars over the years, and it's an honor to be participating in one of them. To your question, you're absolutely right. The problem of cancer treatment is magnified for underserved communities, rural communities, people facing economic difficulties. When you think about timed treatment and the difficulties of getting to treatment, those are magnified when you don't have a car, when you have to rely on public transportation, and even the public transportation may be extremely difficult to access from a rural area. And then you talk about all the burdens that fall on the patient. It's extremely difficult. And I would associate myself with everything that Dr. Rosenzweig said about the difficulties of accessing treatment and really the game changer that subcutaneous injection represents for patients, whether they're the most affluent patient in an urban area. It's still hugely difficult to be dealing with metastatic cancer, or whether they're a patient in a very poor rural area. And the problems of accessing a car and transportation, having a care partner who can help you, oftentimes for poor patients, when you're taking a day off work, that is a direct subtraction of your income. Unlike many people in salary jobs, many people are living in a cash economy. And so if they don't work that day, that's less money, obviously, in their pocket, in addition to the actual costs of the cancer care that Dr. Rosenzweig referred to. So what we are seeing is that the subcutaneous injection is a huge benefit to all patients. And one of the great things is that you really don't have to choose between this dramatic improvement of treatment and reduction in treatment time and clinical efficacy, because, of course, the subcutaneous injection has gone through testing and approval and should be equal to traditional infusion. So what we're seeing is that this is subcutaneous injection is just positive all around. And it's the kind of innovation that we should be encouraging rather than discouraging, which unfortunately this proposal, and I know we'll be talking more about that, but this proposal really, unfortunately, is heading in the negative direction.
Thank you. And I don't know if you want to answer this, or we may shift it to Michael Pratt, but my reaction at this point is that as we continue to work to assure that that clinical innovation is incentivized and made available to more patient cohorts, we have to broaden the conversation regarding the what's necessary to support to create a responsive, welcoming environment within the patient universe. The patient is no longer a passive recipient of treatment, but must be actively engaged, actually far past the sort of the interaction with the clinical world. That's my reaction to what I'm hearing, and I'm encouraging us to continue to work together to assure that as we expand the conversation regarding how our health services system is designed going forward, that we remember always to bring the patient in at that first level of conversation, not as an afterthought, which we have tended to do. And I'm not accusing you, I'm saying we all do.
Absolutely. And not only bringing in the patient voice, but ensuring that the patient voice itself is representing a wide and diverse coalition of patients, because people do have unique perspectives and unique experiences. And we were talking rural, urban. The challenges of anybody facing cancer or any lethal and chronic disease are considerable. And that's true for the rich, for the poor, what have you. But obviously, those problems are magnified the less resources that an individual patient has. Dr. Rosenzweig mentioned about the difficulty of asking a family member or a caregiver to accompany one to say a chemotherapy session, or whether for subcutaneous or just traditional infusion. And it's one thing when you do it as a one-off. It's another thing when you do it for years and years. And for example, my mother dealt with metastatic breast cancer for 16 years. And she was very fortunate that, the family was close by, and so we could help her out on that. But many people don't have those resources near them. And so that's why when people like CMS are evaluating proposals like the current one, it's essential that we get the patient voice to them, and that we get, as I mentioned, a very diverse coalition, so they're understanding the specific perspectives of rural patients, patients from tribal areas, patients from underserved urban populations, and so forth.
Thank you, Steve. I'd like to now turn to Mr. Michael Pratt, but before I do, I want to encourage our audience to please enter any questions you may have in the Q&A portion, in the Q&A section of this Zoom call. We look forward to hearing your reactions to what you're hearing as we continue to seek pathways to encourage CMS and others to include these new therapeutic options in their financial algorithms, but also make sure that we're not forgetting that the patient and family and community are now a much more active, formal participant in the conversation. So, Mr. Michael Pratt is our next panelist. Mr. Pratt is Chief Communications Officer for the National Pharmaceutical Council. Michael, from a policy design standpoint, how should CMS balance the objectives of the Medicare drug price negotiation program against the risk of dampening incentives for patient-centered innovation?
Thanks, Gretchen. It's so great to be here. At the National Pharmaceutical Council, we're a 70-year-old health policy research organization that believes good policy begins with good evidence. And so when the IRA was passed, our team of researchers set out to start thinking through what might be some of the unintended consequences that we could see from the reforms that Congress passed and that CMS would begin implementing. And we were concerned that we might see, due to the incentive structure, delayed launches, fewer subsequent indications, which is a huge deal for cancer patients, given the number of second indications or third indications that come in oncology, and fewer post-approval outcomes research that clinicians and others rely on to help make informed decisions with patients about the kind of care that they should receive. And as the IRA has gone into effect, so 2026 is the first year that we have selected drugs for the drug price negotiation program that have effectuated maximum fair prices, which is the price that CMS has set for these drugs. We have begun a line of research on what we're actually seeing happening. And some of the things that we were concerned about, sure enough, we're seeing. I mean, the peer-reviewed research that NPC has put out has found that since the passage of the IRA, there's been a nearly 40% reduction in industry-funded post-approval clinical trials. So that's trials for second indication of drugs. And an even bigger drop if you looked at just small molecule drugs, because the IRA treats small molecule and biologic drugs differently. When we looked at orphan drugs specifically, there was nearly 50% reduction before the passage of the Orphan Cures Act last year of drugs with one orphan indication getting a second or other orphan designations rather for drugs since the passage of the IRA. So the takeaway here is that policy structure and incentives do change behavior. And so when we take a look at fixed combination drugs, there's a similar concern. And Shaylee did a great job of highlighting some of the concerns here. But if we're not going to treat these innovative products, which, I'm lucky to work with a bunch of pharmacists who have tried to teach me things about pharmacokinetics, and the amount of effort that a research team has to go into to figure out how to deliver a drug molecule through a different delivery mechanism is just fascinating. If you've ever had a chance to spend time in an R&D lab at a drug manufacturer, you'll see that energy from the team of researchers there trying to figure out how to armor a molecule and get it, to go through correctly. So in the world where we are, if you zoom way out on the IRA, the CBO is projecting it's going to cost more. Other research is showing that patients' access to drugs is concerningly being restricted given other Part D mechanics. And if we're losing or risking future innovation that patients are counting on, today's treatments and tomorrow's cures, I'm just not sure that the law is doing what it was intended to do. So the research is showing that there's a lot to be concerned about here.
I want you to feel free to expand upon that, but I'm also going to, as I sort of read back the question that I asked you, which was the balancing the objectives of the Medicare drug price negotiation program against the risk of dampening incentives for patient-centered innovation. The concern I have is on both sides of this, we're talking about money, and which is extraordinarily important, but I want to make sure that we're factoring in the potential for improved outcomes of care as we facilitate access to the market for this form of therapy, which not only is made manifest in money, but also in the quality and quantity, if you will, of the patient's life. So I'm going to ask you, and then when we come back to the other panelists, give them an opportunity to speak to that as well, because what we're always, in theory, speaking of here is a better treatment and outcome of care for patients, for the human beings who are the subject of these conversations. So I'll open that to you.
No, thanks, Gretchen. Look, we're only in the first set of drugs that have had a price set, and I guess two sets of drugs have had some type of explanation from CMS about prices. And if you look through, our team did a research project on what the patient listening sessions that CMS did, and then how some of the input from patient groups and others were factored into what CMS calls the concise justifications around the prices of the drugs. And there's a real open question about how they are currently factoring in patient preferences and patient input, and how they are attempting to, is the price they're driving at value, or is it simply cost savings? And depending on the answers to those questions, the thing that we're seeing is that, you're changing behavior from both patients, manufacturers, payers, and others. And so that's why this comment process is so important, so that way they get some of those perspectives to help inform where they go next.
Okay, thank you. And sort of a follow-up to the follow-up for you is, are there examples in your memory from past CMS rulemaking during which stakeholder feedback meaningfully changed a proposal's final shape, excuse me? And in your view, what made that possible?
So when I worked at the Department of Health and Human Services, and we certainly learned a lot about the Administrative Procedures Act and sort of the process of going through notice and comment and rulemaking. And, look, one relevant specific example is that in the guidance last year, the proposed guidance, they had a different approach toward handling QSSD and fixed combination drugs. And they didn't finalize that given the amount of feedback that they received last year. And this year they've now come back with a different version that they are terming as narrow. And as others have pointed out on this call, it may not actually be that narrow. But at NPC, I firmly believe it's something that we talk about all the time. That good policy begins with good evidence. And so the more stakeholders that share the data, the evidence, the experience that they have with the agency to help inform those decisions, that is the kind of thing that they take seriously. Now, CMS may say, based on the statute, in other situations, our hands are tied, or this is something that Congress, or we have to fix through legislation. But for the things that they have the authority to, and stakeholders can remind them of the authority that they have based on various readings of the statute, evidence is a big part of what they're looking for to really understand how it's impacting patient access and in the Medicare program beneficiaries.
Okay, thank you. I'm going to open this next question up to everyone, but since you're already on the mic, Michael, I'll ask you to answer it first, which is essentially, how do you view the connection between this type of care innovation and healthcare equity for different patient cohorts? And by healthcare equity, what I'm speaking to is, as we move forward, no longer structurally rationing access for any population cohorts, because that's actually what the inequities are to a significant degree in our society. Michael first, then Steve, then Peggy, then Shiley.
Well, I think it's been said well on this call already, and I know Dr. Puckrin's post in Health Affairs talks about this, just the difference in time commitment that this type of innovation, specifically moving from intravenous to subcutaneous, is massive for someone who doesn't have the time, whether financially or time-wise, to go in for that treatment. You would never want that to be the barrier to them getting really important care that can help them live a healthier life, achieve better outcomes, spend more time with their loved ones. And that's really important for us to protect and make sure that we are helping patients that don't have good options today still have hope that they can get options that work for them tomorrow.
Okay. Steve?
I agree with everything that Michael just said, and anything that reduces time of treatment, anything that increases the effectiveness of treatment, helps to reduce health disparities. And the feedback that we've gotten from patients, from caregivers, from oncology nurses, and from physicians regarding subcutaneous injection has just been uniformly positive. And it's this kind of innovation that we hope to see encouraged rather than discouraged.
Okay, thank you. Peggy?
I think every time there's intravenous access, there is, a slight risk of infection. Of course, subcutaneous injections have tiny risk of infection, but nothing like intravenous access. And so, we think about the potential toxicity of these repeated the repeated need for access, and it adds to, again, this patient burden. The equitable components are probably time and money, and the burden that this chronic therapy places on patients. I think the other probably component of this is that patients often don't understand everything about their therapies. They feel sometimes like they're sort of blowing in the wind, and they're told to do this and they're told to do that. And some of our research has looked at different populations in the way that they interpret what is said to them, or the symptoms that they experience, or how they understand their therapy. And this is for stage 4 cancers. And it's very interesting that lower income patients, in our case, both Black and white patients, felt they really didn't understand what the goals of therapy were, or and felt that it really wasn't that well explained to them, and often said, I just do sort of what I'm told. So I think when you start to say, well, we're going to switch your therapy now from something that you really like, sub-Q, to something back to intravenous, or there's not an option for you to have sub-Q therapy that other people have, it's not, you could explain it in many ways, but often patients are not going to understand that and sort of feel like, well, it's just another thing that's sort of being done to me. And often patients who are Black will say, because I'm Black, or patients who are poor will say, because that's just the way life has always been for me. And it kind of compounds this idea of really not having strong advocacy in one's own treatment, and not being heard. That if something's working out for you and the sub-Q therapy is really great, and then, well, that's no longer an option. Or other patients say, well, you got sub-Q therapy, why can't I get that for my treatment? And the answer is, well, they're not really developing these drugs anymore because they're not going to be covered. It just compounds this idea of, I'm sort of not that important. I don't really have a strong voice here. So I think
Thank
it
you.
will affect patients in different ways. More educated, wealthier patients may say, okay, I'm mad about this ruling, but I understand where it came from. But others might not, and just feel like, well, it's part of the ways of the world, sort of in the way that I am treated.
So just to follow up on that, what you're suggesting is somehow one's educational level makes it either easier to understand
Of
these
course.
technical issues, or do we also have a delivery system that's engaging with them because of a presumption that they have not only can understand but have agency
I think the
to
delivery system
engage?
engages patients as if they believe that people understand way more than they understand, and sort of the patients are embarrassed to ask for clarification, or feel like I'm not going to understand it anyway. So there's a sense of, well, I explained it, but if you go back and ask the patient, it's not, I didn't understand what that meant at all. And so people kind of take information and make it in the sense that they understand it, that this is just something else that, was kind of done to me. Something was working, so it got taken away. Kind of that theory.
Thank you. Shiley, the equity question.
Yes, and I'll echo what a lot of my fellow panelists have said, that subcutaneous therapies can offer such meaningful improvements to patients' lives, and in the form of reduced travel time, the time toxicity point that we've all made here, reduced travel time to healthcare facilities, options that make it easier to fit treatment into patients' everyday lives, whether you're a working individual, seniors, or patients living in rural areas. I think subcutaneous treatments have offer the option for general improvements for patients.
Thank you. So I don't see questions from the audience. I don't know if Dane is seeing something I don't see. My question for you all is, in addition to these, to the coverage issues that we're discussing, are there diagnosis and treatment guideline issues that also may affect this, that may compromise the ability of clinicians to prescribe certain forms of therapy? I have no preconceived notion about the answer, but somehow often what we find is that the clinical community's guidelines have not are not current with current technology. Am I wrong or right in that assumption? And do we have work to do with the medical community in the diagnosis and treatment area, regardless of the sort of geopolitical location, whether it's urban or rural, regardless of race or ethnicity, regardless of insurer or payer? Where are the challenges there to anyone?
Gretchen, I'll jump back to something I mentioned when I was speaking before. One of the concerning potential unintended consequences of the IRA is, given the clock that was established for price setting or the selection for the drug price negotiation program, that it would disincentivize trials and other post-approval research that takes time and takes resources to develop that help inform these conversations. And so, in year one of effectuation, we may not have seen that yet. And yet, if we have challenges with that today, as you laid out, there's a threat that the kind of incentive structure that we have in the IRA and sort of a hostility in some cases to innovation that could make that potentially even worse down the road, which is something that we'll be keeping our eyes on here at NPC.
Okay, thank you. Our audience has not submitted any questions, and so I will offer to all of you an opportunity to make a final statement or a take-home message for our audience. And before we go there, state that if any of you are willing to come back and have further conversations about the other rules that are in this sort of spider web of proposed rules that with which we're all contending this summer, I look forward to following up with you, and it includes rules on insurance and the reference countries and issues like quality adjusted life years that is rearing its ugly head again, and how that will compromise the ability of populations who are traditionally marginalized to access these new therapies as we go forward. So, final messages from any of you.
I believe uncertainty is the key here, and that's what these kinds of rules do, particularly when there's not a lot of detail about, well, exactly which drugs will it be, and what does this mean for development going forward. I think it's hard for clinicians, for doctors, for nurses, for pharmacists to adapt to new things. And so in clinic, people become very comfortable with the way that they've always done things, and to take on new formulations or new ways of drug delivery is sort of a leap of faith on the part of the clinicians, particularly the physicians. So to have this changing, or to say, well, we have it now, but it might go away, or there's not going to be development of this in the future, it's hard. It really does squish and put a damper on innovation And it's innovation across the board, not just at the companies to develop these drugs, but for the clinicians to adopt the drugs and for the nurses to be comfortable teaching patients about the drugs and the pharmacists to work with the nursing staff, everybody to learn new things and new ways and better ways to deliver them. And when that changes, it sort of goes backwards. It's a really, really dampening effect. So we talked a lot about the patient perspective, but there's a big clinical component of, changing these big ships of the way we deliver care. And so when there's uncertainty about that, or even rumors, and probably really online for all the, patient advocacy groups, oh, we heard this is going to change, this is going to change. It makes people upset and then unlikely to change what they've already been doing because they're like, oh, no use learning that or doing something different because it's just going to change back, or we're not allowed to do that, or it's not going to be covered. It has a very dampening effect.
It is, that's concerning. Shirley?
I'll piggyback on what Dr. Rosenzweig has said about uncertainty and how the lack of predictability about how CMS is going to change these proposals from year to year as part of the drug price negotiation program makes it really difficult for innovator companies to make decisions, not knowing how their investments in clinical trials to bring these types of drugs to market is going to pan out over the years. Treating IV and subcutaneous forms of treatment undermines the value that this brings to all patients, whether it's seniors, patients living in underserved areas, or working families. And it's just important that patients can access all different kinds of options for their treatments to reduce the burden of care that they and their families experience. So I would just encourage folks to take advantage of the open comment opportunity. It closes on August 17th at 5 p.m. And you can submit your comments on regulations.gov and really echo what your concerns would be if this kind of policy from CMS were to be finalized.
Thank you. Steve or Michael?
Yes, I would just echo what Shaylee just said about the importance of submitting comments. And at ICANN, International Cancer Advocacy Network, our primary constituency are stage 4 cancer patients, the most serious stage. And our patients are tremendously dependent upon the drug development pipeline. And this proposal, unfortunately, and there are many other proposals, directly affect and directly undermine the drug development pipeline. And we need to do everything we can to get across to CMS the importance of encouraging rather than discouraging drug development, innovative methods of delivering medicines. And I would just encourage any patients, any patient advocacy groups that may be watching to submit comments. As Shaylee said, they don't have to be professional. They're not looking for a legal brief. A lot of times, just the heartfelt opinions and experiences of patients and patient advocates are what matters. And so I would just really encourage people to not just watch the end of this webinar, but to just take the time. It can be done in 5 minutes, 10 minutes, 15 minutes. Submit comments, as Shaylee said, at regulations.gov. And I know we're going to follow up with information about this process. And I think it can hopefully make an impact. And again, thank you for sponsoring this forum. I think it's a very important message. And I just hope people will follow up.
Thank you. Michael?
Well, Gretchen, thank you for hosting this really important conversation. I work at an evidence-driven organization, and so when I look at the evidence that us and others have put out, the IRA is a poorly designed program that is harming innovation. It is unfortunately creating some access restrictions, and it's costing far more than it was originally projected. And so CMS has tools at its disposal to, within the limits of the statute, make it better or worse. And so the importance of common opportunities like this are to help inform those decisions. And, if anyone is interested in some of the research that I spoke about, we have a weekly newsletter that you can subscribe to at npcnow.org, or drop us a line, and we certainly are happy to share the research that we've produced related to the early signals of the impact of the IRA and other topics.
Okay, thank you. And I do have a note from Mr. White that we received a question. Can you share the question with us, Dane?
Absolutely. So Paul says, what would be the top 3 points that congressional policymakers should make to CMS about this proposed rule?
Any takers? Of 1, 2, or 3 top points.
Sure. Very quickly, that it undermines innovation, it undermines investment, and therefore it's going to undermine and hurt patient treatment.
I second
And I
all
think-
of those.
And I think I'd add there's, concern with this one particularly, that CMS is choosing a different framework from FDA's.
Excellent point.
Thank you. So I'm going to thank our panelists for sharing their knowledge and perspectives today. I will say to the audience that if questions surface once we've adjourned this session, please feel free to send your questions to Dane White at dwight@nmqf.org, or you can send them to me, and we will do everything we can to get answers to you in time for you to include that answer, if you're so inclined, in a public comment. Thank you so much for staying with us and spending critical time with us these days. And please enjoy the rest of your day. This webinar is adjourned.
Thank you.
Thank you.